Introduce the French group. So we have Dr. Thomas Wirth from Strasbourg and Dr. Doummar from Paris and no, Sorbonne, yes. And then we talk about the dystonic phenotype. About the dystonic phenotype related to GNAO1. Thank you.
Okay. No, backward. Okay. So thank you for inviting us to talk about our work entitled Highlighting the Dystonic Phenotype related to GNAO1. So I'm Thomas Wirth from Strasbourg University Hospital. And
I work in Paris in Trousseau Hospital, a neuropediatric hospital, and we initiate the work of milder phenotype together, and we'll make a
common presentation.
Yes.
Yeah.
So a short introduction. Dr. Galozzi talk about physiopathology. So just to say, GNAO1, it's widely expressed in CNS and play an important role in signal transduction, so CAMP, metabolism in the striatum. GNAO1 pathogenic variant have been associated with the two severe phenotypes. The first reported was in 2013, and the phenotype was early infantile epileptic encephalopathy with sometimes suppression births. And the other one, presented by several authors, is a neurodevelopmental disorder with movement disorder, dystonia or chorea or both, with often exacerbation, paroxysmal exacerbation or status dystonicus, as we can show in this video, associated with severe intellectual disability with or without a seizure. This boy presented a severe phenotype with hypotonia, dystonia, and seizure.
So I'm going to talk about the initiation of our project. I used to work on the genetic basis of dystonic syndromes of adulthood onset or late adolescence onset. And in this work that was published in 2020, we analyzed two autosomal dominant family of focal or multifocal dystonia. And so you can see the pedigrees of these two families that were associated with two pathogenic variants in GNAO1 that were segregating with the disorders. So we were pretty surprised because at that time, when we analyzed this patient in 2018, GNAO1 was only reported in much severe phenotype, epileptic encephalopathy, or the clinical picture that Diane presented previously. But some of these patients were showing isolated segmental or mandibular and cervical dystonia with an age of onset at 15 years. Some patients were even showing isolated cervical focal dystonia beginning at 47 years of age, so pretty late in life. So these phenotypes were quite atypical. And I saw the variants were inherited while only the novo mutations were reported at that time. So we decided to go further and try to identify other patients with milder phenotypes. So the objective of this study was to describe the wide phenotypic spectrum associated with GNAO1 pathogenic variant, the clinical and the genetic characteristics, through the creation of a very large cohort of patients with mild phenotypes. Okay? So to do this, we decided to select milder phenotype defined by the lack of severe or profound intellectual disability, the occurrence of movement disorders after 2 years of age, the lack of early onset epileptic encephalopathy, and more importantly, the acquisition of work. We interpreted the variants according to the American College of Medical Genetics and Genomics. We filtered these variants using the public variant repositories, 1000 Genome, Exact Genome ID, and use in silico tool to predict the pathogenicity of those variants. To create the cohort and to expand the cohort, we used the collaborative platform GeneMatcher. So to introduce GeneMatcher, you can see this as a dating application for geneticians. Basically, you just put the gene on the platform, and then you can interact with other collaborators that have an interest in GNAO1 disorders. So through this platform, we were able to identify 18 centers from 6 different countries: USA, France, Israel, Switzerland, Italy, and the United Kingdom, that were interested in participating in this global initiative to describe these milder phenotypes. Doesn't work?
Yes. What are our results? We included 25 patients, 15 female. 7 patients were from 3 families showing autosomal dominant inheritance pattern. 17 were sporadic due to de novo mutation. And the mean age at disease onset was 6.6, ranged from 4 months to 47 years. And what are the clinical presentations? Developmental delay was the first presentation in the 54%. 4 had language delay, 9 motor delay, and associated with 4 with hypotonia. 40% had predominant dystonia, 10% the patient, and seizure in 1 patient. So dystonia was the predominant movement disorder in all patients. With a mean age of onset, 10 years, range from 2 to 47 years. And the dystonia was in 25% isolated, unique symptom in 6 patients with later onset occurrence during adolescent or adulthood. In 75%, dystonia is combined to Parkinsonism, 7, myoclonus, and chorea in 2. Only 3 patients presented paroxysmal exacerbation. Dystonia was associated to intellectual disability in 12, mild in 10, and moderate in 2. So no cognitive impairment in 50%. Seizure only in 3 patients in the cohort. The distribution the dystonia was generalized in 54%, and the segmental, multifocal, and focal with upper body distribution, brachial and cervical in 46 patients. The dystonia was associated with oropharyngeal dystonia, responsible to language difficulties and dysarthria in 80%. There is a progressive course of dystonia in 54%. What about the response of treatment? We use medication, symptomatic medication, with a variable effect. The effect was partial to anticholinergic, 6/15, and levodopa, 6/13. And the effect was very poor to tetrabenazine, amantadine, clonazepam, and methylphenidate. I tried caffeine in one patient, a girl, at 8 years. She presented early onset hypotonia, dystonia, and perioral dyskinesia. So I tried caffeine, but it worsened dyskinesia in this patient. Well, it's not the same for maybe for all the patients, but for this one, it was not good. What about deep brain stimulation? It was responsible for a significant improvement in 5 patients.
Out of 6.
No.
Oh, no, it's still.
Here's Bruno is a 20-year-old patient. He presented during childhood learning difficulties with ADHD, but without intellectual disability. Methylphenidate was introduced with some benefit, but it was stopped when he was 11 years. Then he presented brachial with writing difficulties, cervical dystonia. Methylphenidate was reintroduced, but without effect. And the dystonia increased, associated with Parkinsonism. As you can see, he presented axial dystonia with backward head throws, very disabling. He is very slow. He can eat, but with difficulties when the head go back. And he was the DBS was performed when he was 20 years because of exacerbation of this axial dystonia. And there is a partial improvement of this axial dystonia, but not on the baseline dystonia and Parkinsonism.
So I'm going to present the next 2 videos. So the first patient, this woman was one of our first autosomal dominant families. So she had an onset of a dystonia at 5 years of age, which was generalized. You can see on the video an actual involvement, but which is pretty mild. She had some intellectual quantitative measurements, and she had normal IQ, and the dystonia was non-progressive for her entire life. She gave birth to a boy who was showing milder generalized dystonia as well, with very mild intellectual disability. So now you can see this patient at 64 years of age. After multiple exploration for a dystonia, she underwent deep phenotyping in the 60s and the 70s, but without obvious diagnostics. In 2018, we identified the C215Y mutation in GNAO1. So you can see it's a pretty mild phenotype. So that was the onset of our project. She can rise, she can live independently. There is no need for help to perform her activities of daily living. So she's pretty happy. And you can see these other patients, thanks to Giacomo Garone, who's followed at the Bambino Gesù Hospital, who's having some a little bit more severe dystonia, I would say, with axial involvement, upper limb dystonia, lower limb, some kind of mobile dystonic movements. Some of them could call it chorea, and with also some abnormal postures of upper limb that is activated by voluntary movements. So you can see on the right hand some mild dystonic posturing, also on his face, on his left limb. So there's a little bit of asymmetry in this patient, which is something that we can observe in other GNAO1 patients. So in a few seconds, we are going to see him, to see his gait, hopefully. So you can see other dystonic movements. So now he's going to, you can see also a cervical involvement, which is going to be much more noticeable when he will start walking in a few seconds. So it's a shame we don't have the sound because he was speaking. There was also a laryngeal component of things. So and you can see that the dystonia is activated when he's walking as well. Okay, so here there is a representation of the GNAO1 protein on the right corner. It's the green three-dimensional structure of the protein. The blue protein is its beta partner. So GNAO1 is the alpha-0 subunit of the heterotrimeric G protein. In gray, you can see the gamma subunit. So what you can see in the lower figure on C, you can see all the variants that were reported at the time we published our manuscript. So in black, the variants that were associated with severe form of the disease, and in red, the variants we identified in our work. What was pretty interesting is that most of the variants we identified were not previously reported in the literature, which strongly argues for some kind of genotype-phenotype correlation. Also, they clustered in the same area than the other variants. So it's probably not a matter of functional domains, but rather an effect, a direct effect of the variants. We identified as well some loss of function variants that were associated with pretty mild phenotype, which is in accordance with one of the posters that I've seen earlier. And so we published a manuscript based on our findings, and we received a reply from the Michael Zeck's team in Munich, who described another autosomal dominant families whose patients were carrying loss of function variants, adding to our previous description of three autosomal dominant families with milder phenotype associated with GNAO1 variants. Okay.
So in conclusion, it's the largest reported cohort of patients with mild phenotypes and mutation of this gene, and with the characteristic phenotype of generalized dystonia, mildly progressive, and with some patient only upper body distribution. Dysarthria is very frequent. Description of Parkinsonism. What about the asymptomatic carrier?
In one of the autosomal dominant families we studied, we identified a completely asymptomatic carrier of the pathogenic variant we identified, which raised the question on whether or not there could be either incomplete penetrance or very late onset of the disease. It's the family where one of the patients carrying the variant developed dystonia after 40 years of age, and this patient was 30 years of age, so we can't definitely rule out that he won't develop the disease later in life. So as we said, there is a probable existence of a genotype-phenotype correlation. While there is no specific localizations of variants in our cohort, we identified two loss-of-function variants in two families with mild phenotype, which runs against the hypothesis of a direct correlation between loss of function variant and developmental epileptic encephalopathy and gain of function or neutral variance and neurodevelopmental disorders with movement disorders and dystonia. We highlighted a good response to deep brain stimulation in the majority of the patients. The only one who did not really improve that the severe oromandibular component, which is something that is described to not respond pretty well to GPI-DBS usually. So thanks to our work, we were able to publish, to report these findings into a manuscript that was published last year in Movement Disorders with the help of all these collaborators worldwide. So we wanted to acknowledge all the patients who participate in this work, all the neurologists and neuropediatricians who helped us to recruit and deeply phenotype these patients. Of course, the team from Strasbourg University Hospital, the team from my lab, the Institute of Genetics and Cellular and Molecular Biology, Trousseau Hospital. Special thanks to Manju Kurian and Giacomo Garone, as well as Laura Sif from Montpellier, as well as the funders, the France Parkinson Organization and the French Society of Neurology who funded me for this work. Here we are.
Thank you.
Thank you very much. Very interesting. So I think we have a time for, okay, 2 questions.
Thanks a lot for this excellent work, very interesting and informative. I have a question about levodopa. My impression is that levodopa seems to be helpful for more patients with the mild disease rather than for patients which have the more severe forms of the disease. Can you confirm whether this is the case or not, and can you speculate on why this could be so?
I don't know, but in this cohort, the response was partial in 6 patients only, but very partial. CSF neurotransmitter was performed without low level of dopamine.
In my experience, the benefit is pretty mild. We evaluate the outcome of the medication in this work using a liquid scale, so it's not really optimal. We need a specific score to demonstrate the effectiveness of these therapeutics. What seemed to be more effective was anticholinergic drugs. From the impression I had and from my own experience with GNAO1 patient, we identified 2 or 3 additional patients in Strasbourg recently. Anticholinergic drugs are providing a benefit when surgery cannot be considered, but probably the most effective therapy in this work was the brain stimulation for mild phenotype.
Second question.
Thank you. I was wondering if you could speak a little bit to, as a patient family, we get asked a lot about the inheritance of GNAO1 and what's the prospect of that being passed on. Could you speak more generally about what your work speaks to? Thank you.
Okay, so there are 2 possibilities. It's an autosomal dominant condition. So basically, all of you have 2 copies of every gene you've got in your genome. So you've got 20,000 genes, roughly. In GNAO1, GNAO1, if you've got 1 mutation on one of the 2 copies of the gene, it's sufficient and necessary for you to develop the disease, the disorder. Well, most of the patients are carrying the novo mutation. It means that it's a mutation that appears during meiosis and spermatozoid or ovocyte production. So usually we say that the risk of recurrence is 1% for the little brother or the little sister, but it's pretty diverging. It's not when you've got a mild phenotype, when you're carrying the mutation, and when you're capable of having an independent life, to meet someone and have a parental project, the probability to transmit the mutation as a patient is 50%. And since the penetrance is almost completely complete, then there is 50% of risk for your child to develop the disease. And you cannot say whether it will be a severe form or a milder form. You have some clue, but there is some variation as well.
There's another question, last one.
Thank you. I would like to know which kind of anticholinergic was effective, the molecules.
3-hexyphenylene.
Diartan,
It's difficult to.
diartane.
Okay, thank you.
Okay, thank you very much.
Thank you.
So I like to